When he comes, he's going to take some more.
Good evening, ladies and gentlemen. As a multinational company, Sanofi is happy to collaborate with IMPA in updating scientific knowledge and medical updates. This is the first joint CME titled Debunking the Myths and Stating the Facts of Modern Sulfonylureas and Acute Coronary Syndrome. Before we start the proceedings, I may invite you to kindly stand for the national anthem. Thank you, everyone. On behalf of IMPA, I would like to invite Dr. A.H. Hasari, the President of IMPA, to do the welcome speech.
Good evening, ladies and gentlemen. On behalf of the IMPA, I will first and foremost apologize for the delay in starting of today's program due to technical and non-technical reasons. First, let me thank the moderator of today's program, Dr. Henry Rajaratnam, for having in 1980, and I learned a lot of medicine from him. Thank you, sir. And our two distinguished lecturers, Dr. Manilka Sumanathilag, the endocrinologist, who will speak to you very shortly, and Dr. Upul Vikramarajji, the consultant cardiologist at Lanka Hospital, young up and coming doctor. And I would also thank you all for participating in today's function on behalf of the IMPA, because we've not been having physical meetings for at least 6 months because of the situation in the country and all the other technical matters. So I would also like to thank the sponsors of this evening, Dr. Sanofi Aventis Bauer and Company, who are sponsoring today's program. And because we are unable to have everybody to participate physically, this program is also going online, and it will be available also on our website, when you can watch it later on if you need to. So since it's running late, I would now hand over to the organizers to continue. Thank you.
Thank you, Dr. Hasari. Now I would like to invite Dr. Kaushalya Jayavira, the medical advisor of Sanofi, for the introduction of the chairperson.
Thank you, Sandhya. Good evening, ladies and gentlemen. Welcome to everyone here, and good evening to everyone joining us through the internet. So we're going to have two lectures today by two eminent clinical consultants, and it's going to be I hope it will be a very interactive session, and I hope everyone on the internet would be able to join us with your questions as well. And without further ado, I'd like to introduce our chairperson. So it's an honor and a privilege to introduce Dr. Henry Rajaratnam. He's a senior consultant endocrinologist. He's the first chairman of the committee to establish endocrinology as a subspecialty in Sri Lanka. He's a pioneer endocrinologist in Sri Lanka, the president of the Ceylon College of Physicians, a trustee of the Ceylon College of Physicians, the president of the Endocrine Society from 1993 to 2003. He's also the patron of the Endocrine Society of Sri Lanka from 2006 up to now. He's also the joint patron of the South Asian Federation of Endocrine Societies and compiler of the Endocrine Update of the Endocrine Society of Sri Lanka, compiler of the Medicine Update for the Ceylon College of Physicians, and author of several publications in peer-reviewed local and international scientific journals. He's lectured both nationally and internationally in India, Malaysia, Myanmar, Indonesia, and Pakistan. And he's delivered two orations, the Professor Rajeshwari oration, and also the inaugural Deshamanya Dr. R. Ramachandran oration on diabetic remission after bariatric surgery. And he's been honored by the Endocrine Society of Sri Lanka with the Dr. Henry Rajaratnam oration, the first of its of the society. So, sir, I would like to now hand over the session to you.
Thank you. Ladies and gentlemen, first I need to apologize for the meeting to start late. Just due to the fact that I was not picked up on time. And so you might say, for God's sake, take me to the lecture on time. Okay. So let's start up. Manilka, are you ready? Okay. So the first lecture is by Dr. Manilka Sumanathilaka, who is a fellow endocrinologist, a MBBS, the MD from the University of Colombo, an MRCP London, an MRCP in Diabetes and Endocrinology UK, FRCP of the Edinburgh College, and a fellow of the American College of Endocrinology USA. He was trained in endocrinology at the National Hospital of Sri Lanka and St. Bartholomew's Hospital, London. And today he's a senior consultant endocrinologist at the National Hospital of Sri Lanka. He was also the president of the Sri Lanka College of Endocrinology. He has many publications, but the most important thing was invited to write the chapter on endocrine emergencies in pregnancy by the famous Sri Lankan Dr. Sir Sabaratna Marul Kumaran and Edwin Chandraharan, published by the Cambridge University Press. He has many research articles on multi-center randomized control trials on a new DPP-4 inhibitors. He has described the syndrome of insulin autoimmune syndrome causing hypoglycemia. He has written on diabetic autonomic neuropathy and conducted the efficacy studies on alendronate and innovator ibandronate in postmenopausal osteoporosis. I have now great pleasure in inviting Dr. Manilka Sumanathilaka to deliver his lecture on debunking the myths and stating the facts of modern sulfonylureas. Dr. Manilka.
Good evening, everybody, and thank you very much, sir, for that kind words of introduction. And I'm privileged to be with him. He's a person who has nurtured us, encouraged us, and brought us to this level. And thank you, sir. I take this opportunity to thank you for that as well. And so in the era of DPP-4 inhibitors, GLP-1 receptor agonists, and, lots of new exciting medications, coming into the market. Once weekly preparations, once weekly insulins are around the corner. So we are going back the full circle and coming back to our good old sulfonylureas. So the myths that we are talking about, how do I change? Okay. So until they get the slides. So now the Western world, I was there for the recent American Diabetes Association sessions. There was not a single session or a lecture on sulfonylureas, because it's purely, it's a hype of, newer drugs driven by the industry. And if you look at the cost, one of those injections, it's like $400, $500. And especially in the current situation, we'll be round the full circle and coming back to our basics. And I thought this was a very timely lecture to brush up our knowledge and learn about the new preparations and how we could manage our patients in a cost-effective manner. Those drugs are, wonderful, blockbuster drugs, which reduces the weight, all that, but the cost is prohibitive. And unfortunately, I think for us, it may be many, many years away. So we'll have to learn to manage with the old groups, but there are newer preparations. So that's what I'm going to say. If I can, problem with the slides. Slide, it's in my laptop. Sorry about the slides, they couldn't trace. So the sulfonylureas, when you say modern sulfonylureas, I'll get the ball rolling until they get the slides on. You all may be familiar with tolbutamide, chlorpropamide, glibenclamide those days. So those were the more like first generation sulfonylureas, which had their own, pros and cons when it comes to the treatment. So the glibenclamide, the most commonly dianyl used one, which has a very long half-life, which is 36 hours. So the main problem with that was severe hypoglycemia, especially in the elderly. So we had the choice of a short-acting tolbutamide those days, which we don't use much now. And that was a short-acting one. Hypoglycemia is less good for elderly, and even in renal failure, we used to give that. But the newer second and third generation sulfonylureas, they have improved on their efficacy plus the side effect profile. So glycoside and glimepiride are the newer, what we call as the modern sulfonylureas, which is the topic of today's discussion. And glimepiride is a long-acting preparation, but it binds to the sulfonylurea receptor, which is in the pancreas in a different way. It does not bind very tightly compared to the other older sulfonylureas like glibenclamide. So they claim that the hypoglycemia risk is much less and much smoother action. And the main concern when the newer drugs came in diabetics was the cardiovascular risk profile. I think it's important for the cardiologists in every one of us, because most of our diabetics will die of a cardiovascular problem. 65% of the deaths among diabetics would be in diabetes will be a cardiovascular problem, right? So these older drugs increase, there was a theory that it will increase the cardiovascular risk. I will explain that when it comes to the slides, which is called, it prevents the cardiac, preconditioning. So that's what is not there in the newer one. So let's get on. Thanks. Sorry about the, yeah, okay, no? So, okay. So now the objectives will be, because when the newer preparations, DPPI, it's gliptins, empagliflozin, all these came, these were the plus points that they showed: less hypoglycemia, less weight gain, beta cell exhaustion, the theory about depleting the beta cells with the older preparations, efficacy and durability of glycemic control, and the cardiovascular profile, which I started explaining about. So let's see. Okay, so if you look at the literature, you will see that the Western world, the so-called the Western world, will not have much literature. It's only in our subcontinent and our group where Sir also got involved in the surface that we have newer publications on the sulfonylureas, because it's in this part of the world that we use all these preparations mostly. So this was Indian colleagues that they have done in their own journal. And so they are explaining all these things, what I have summarized there in this paper. So let's look at what they call the myth about weight gain with sulfonylureas. So all these things will apply to glimepiride and glycoside MR, not the normal glycoside. So those two are equal, but there's more evidence for glimepiride, as shown in most of the studies here. And I collected few studies for glycoside as well, which we won't have it now because we could not upload that. So weight disturbances, so is the Western world the main factor that they don't like the sulfonylureas. But compared to the conventional tolbutamide, glibenclamide, which is, we know that people will increase their weight with those medication. These medicines, the studies I'll share a few, will show that the weight gain is very minimal. And if you combine with metformin, as you know, some people will lose weight with metformin, at least it's weight neutral, right? So if you combine the two with the newer preparations, definitely it's almost weight neutral. I won't say that they'll be losing weight, but it is weight neutral. So what is the mechanism associated with weight gain in the sulfonylurea? So, it reduces the sugar levels fast, the glucotoxicity, so-called, very high levels of glucose will come down, and it would, utilize the increased utilization of glucose. And of course, as you know, the insulin levels also will vary when the glucose levels are coming down, right? And there is some preservation of the pancreas in most of the diabetics, 50% at the time of diagnosis. And so the glucotoxicity is removed, there'll be more insulin coming out, which is, insulin is an anabolic hormone, right? So they theorize that the initial weight gain with the sulfonylureas is because of the rapid reduction in the sugar levels. And due to this reason, they'll be putting on some weight, which the person has lost due to the high blood sugar itself, right? Rather than the drug causing a severe weight gain. So, which you can see very quickly. So you can see always the studies have been combining with metformin and glimepiride. So that's why I don't want to say entirely it's purely the sulfonylureas. But as you can see, this study shows that it has been weight neutral over a 5-year period with nearly 3,000 patients, study done in 2016. This is a Western study, and which strict glycemic control and all the targets, reduction of cardiovascular risk, all has been proven by achieving good glycemic control over the 5 years. Baseline to 5 years, it has been weight neutral. So the myth about weight gain with the newer sulfonylureas, this study gives a contradictory message. So this was a large study as well, Carolina study. which, again reassures. This was a head-to-head study between linagliptin and glimepiride, which was, done over about nearly a year, 256. It went on for not year, in weeks, several years, about 5 years, I think, 4.5 to 5 years. And it showed that we know the gliptins, they are weight neutral or they might lose weight, but the difference was about less than a kilo or 1.5 kilos over 6 years. So, I mean, what's the advantage of that when you compare the cost? Now look at the cost of linagliptin in today's context. I think it was like 40-50 rupees, and now it has jumped to 80 or way over the top. And the sulfonylureas are still in the, after metformin, I think the most affordable group of drugs. So when you look at the cost effectiveness, if you compare it, this 1 kilo wouldn't be a huge problem. You can easily lose that with a good diet and exercise regime. What about the myth or the thought about hypoglycemia with these new agents? And it has shown that the stimulation of the insulin release, the attachment, I said it's less stronger than glimepiride, the older ones, glibenclamide in the sulfonylurea receptors of the beta cells. So this is supposed to release the insulin in a more sort of a episodic, sort of a pulsatile manner, right? If you do the physiology studies, it has shown compared to glibenclamide, which whether the sugar levels are high or low, moment it gets attached, it's a tight attachment. It keeps on releasing the insulin until its half-life is gone. Duration of action is there, which is about 36 hours. So this one, it's a lower binding and quick association and dissociation to the receptor, and it gives a much smoother release of insulin, which reduces the hypoglycemia risk as shown by this. So, and for a given, this study has compared glipizide. We don't have it. We have it, but we don't use it much. Maybe you all have used this those days. Gliclazide, the normal gliclazide, is a different one. So they haven't compared the gliclazide MR, which is long-acting, which comes comparable to this, but the normal short-acting gliclazide and glibenclamide and glimepiride, you can see the ratio for a given amount of insulin release for the amount of blood sugar rise or the level in the blood is much less. So basically what this graph is showing is that glimepiride will achieve the good glycemic control with a lower level of insulin release, which is good because we see that even in reactive hypoglycemia, if too much of insulin comes out of your pancreas, the sugar levels come down initially after a high carb meal, but you get a rebound hypoglycemia, what we call as reactive hypoglycemia. So similar picture can be there with some of the older sulfonylureas, because once the action has called, the sugar levels have gone down, still the insulin will be released. So there will be a mismatch between the hypoglycemia in the blood, and the action. So that is what they are claiming, showing in this slide. So they have compared another study with metformin and other thousands of person years. They have combined with the renal functions in relation to renal function and sulfonylurea metabolite group, a cohort study. This is also a foreign study, BMJ 2016, looking at the incidence rate of hypoglycemia. Of course, compared to metformin, it will be high. I wouldn't say it's not there, right? But compared to the other preparations, and it's very good. Look at glibenclamide. So it's 1/3 of the diurnal hypoglycemia rate with these newer agents. Gliclazide and glimepiride would be close, and gliclazide MR and glimepiride will be almost equal or very close. beta cell failure. This is a very popular topic that, a controversial but popular topic. We know that by the time somebody is diagnosed with type 2 diabetes, we postulate that 50% of their beta cell cells have been destroyed. But recently, sir, if you may, you might agree, very recently they said there is nothing called beta cell destruction. It's stunning or, dysfunction of the beta cells. So there is potential to get those cells working, especially with the newer agents that they are claiming, like the twin cretins, SGLT2 inhibitors. If you get rid of the intrapancreatic fatty pancreas they're talking about, not like the fatty liver, these cells, vast number of them can be revived. So that's where the topic of regression of diabetes, now people are trying even to type 2 diabetes with good weight loss and insulin and metformin and other medications, you could reverse type 2 diabetes, especially within the first 5 years. So that's what they are talking about. So there is no destruction of the beta cells. There is, due to glucotoxicity, very high sugars itself, the beta cells will become dysfunctional. I think there was a slide to explain that also. Or if you talk in myocardial things, stunning of the myocardium, I'm sure all of you have heard from the cardiologist, similar thing is happening with the beta cells, which can be reversed. So when the lipotoxicity, if the lipids are also very high, the beta cells can be still affected. So if you get rid of the fat inside the around the beta cells, the islets of Langerhans in the pancreas, you can reverse the function and improve the function. So that's another myth that future research also will need to be done to confirm these theories. So UKPDS also, showed that they gave sulfonylureas for a longer period of time. They didn't see any difference between using sulfonylureas for a long time or insulin, and they said it was almost similar when you analyze the data on beta cell failure. These are older study. Okay, so the concept of beta cell dedifferentiation is more rational than saying beta cell failure or destruction. That's what they are postulating. A bit of a busy slide. So normal beta cells mainly releasing insulin there with little bit of pro-insulin stored. But if the beta cells are challenged by high glucose levels or lipid levels, it can increase the amount of insulin, and with that it can also release other factors like other products like pro-insulin and become dysfunctional after some time, and of course some of it can die as well. This reprogramming is interesting due to many reasons, somatostatins, glucagon. So it can be reprogrammed to release other factors like what you call as stress hormones, or glucagon, as you know, will increase the sugar levels in the blood, right? So it's a complex mechanism. These are theories which people have explained, and to see that the beta cells are there, some of it will be reprogrammed, some a smaller percentage might die because of when they are challenged by glucotoxicity or lipotoxicity. So these are they are just comparing, because these things came with the DPP4 inhibitors and GLP receptor agonists. Those studies, some of those studies, they were claiming that they were preserving the beta cells, and even some studies they were claiming that they were increasing the beta cell mass. So that was the hype about all these new agents, and we sort of somewhat reduced the use of sulfonylureas. And this study shows that sulfonylureas, initially there might be a decrease, but then after that it corrects this imbalance, and protect against the autophagy associated with beta cell failure. This was a bit of old study, but published in a major journal, good journal, Diabetes Care, where glimepiride, they claim, this is not proven, but this particular group of people claim that it actually enhances the beta cell secretion after 6 months of starting treatment. So it's not, proven. It's a smaller study, but that is the thing. Definitely, it's not inferior. It's not causing a harm. That we can say with confidence, but whether it's actually increasing, there is not enough strong evidence to say. So efficacy in lowering hyperglycemia. So as you know, compared the newer drugs, if you read the DPP-4 inhibitors, SGLT2 inhibitors, they have other good effects, SGLT2, but reduction of the HbA1c is like less than 1 in some other thing, 0.75, 0.8. So sulfonylureas, actually it can go 1, generally about 1%, but even above 1. Insulin is the best to reduce the levels by any number over time, 4-5% even, but these drugs also, the efficacy is slightly more than the newer, more expensive preparations that we have. So it works well. All the studies, it's most of the time combined with metformin, but very rarely you see 1 or 2 studies with only the sulfonylurea being given. Always, almost always, it's combined with metformin, as you can see in most of the studies. This was also done in India, I think. Yeah. So this study done by Goldberg et al. Is a very old study, shows that different doses of glimepiride over 14 weeks, how it will reduce. But I wouldn't recommend, I don't know whether Sir will, the 8 milligrams for Sri Lankans. No, we generally go up to about 6, 4 and 2. But this study, they have gone up to 8 milligrams. Like Dianil being given 10 BD, but BNF saying 15. So you could use in certain people under supervision, but I would recommend to go up to 6 milligrams. But the incremental, decrease in the glycemic sugar levels, they have shown a good response with the glimepiride over a period of time. Safety of glimepiride combined with metformin is, a good combination, which we have done for many decades in Sri Lanka. And of course, this one particular study, which they have given the JCM paper, says it's better than metformin and sitagliptin combination in terms of cardiovascular risk reduction and reducing the blood sugar levels initially, more efficacious, and sustained glycemic control patients in the lead-2 trial, which was liraglutide, GLP-1 receptor agonist. So the effects are also more sustained with the sulfonylurea, and even with insulin, they have combined with a good safety profile, long-acting insulin. Glimepiride could be combined with a compared to the older glibenclamide. We would never like to combine with insulin because the high risk of hypoglycemia. But here there are studies to show, the references are given there, that it has been combined. And of course, it's repeating again that it has shown better control over some of the newer preparations. Durability of glycemic control, which is a very important thing for us. And so this is a very large study which has been treated, nearly 20,000 patients on sulfonylureas, DPP-4s, and thiazolidinediones following metformin therapy failure. So we first line anywhere in the world still would be, first line would be diet and exercise, and then metformin, unless there is a contraindication. Then if you can't achieve your target HbA1c, all the guidelines, any of the organizations in the world would say go for a second line, which could be a sulfonylurea, DPP-4 inhibitor, insulin, SGLT2, any of the newer products can be used. So that's what the guidelines say. That this one says that, you know, adding SU will be better in terms of getting a good control, which we see. But others might argue, initially you'll get a good control, but what about the long-term effects? So that's where the myths, and, you know, we were comparing the beta cell failure, beta cell destruction associated with the sulfonylureas are not that, not a problem according to these studies in the newer preparation. So even the long-term sustenance of the durability up to 5 years has been proven. But I think we have experience way beyond that also with these preparations. So here they are looking at durability of sitagliptin plus metformin and metformin plus glimepiride or a glycoside MR, and it shows a marginal better response, which we have been talking about 0.5% greater reduction in HbA1cs associated with the combination. Cardiovascular safety is the main, you know, sticky point. This could be all industry driven also, because the newer preparations they have spent billions in in research, and those companies are promoting those products, and our meetings are full of those lectures, and they fund big studies. Hardly any, over the last 10 years, we haven't seen any big sulfonylurea study, because it's not viable. These are very relatively cheaper medications, and nobody is willing to fund those studies to look at their cardiovascular risk reduction, and hence we don't have data. So Carolina was a large trial. That is all what we have for this, but then it has shown that it has a good cardiovascular risk profile compared to the older preparations, which I was talking about. Ischemic it's there, the slide. So ischemic preconditioning, it's a interesting side. I think we have a cardiologist speaking after me. I'm sure he'll be talking about it and he can explain it better. So there can be, what you mean by ischemic preconditioning is a repeated and brief occlusion of the same vessel preconditions the myocardium. I suppose these collaterals are forming and all that. No? So he should be able to explain that better. So the older sulfonylureas are supposed to block this phenomenon, getting the collaterals done. But the newer preparations, they have shown that it will not have the effect. Glimepiride especially, and glycoside MR is proven to have not to cause a problem with ischemic preconditioning in the myocardium, which is very, very important for diabetes. And the studies also have shown that it's similar. The ST segment shifts during your procedures, a bit technical, this study, but practically what it says is compared to glibenclamide, glimepiride is almost equal to a placebo when it comes to causing during the percutaneous transluminal coronary angioplasty. And looking at the ST segment shifts, it's a bit of a technical thing, but it just shows that it does not have a sort of a negative cardiac effect or a detrimental effect on the myocardium, ischemic myocardium. Mortality, when you look at all the preparations, you can see that glycoside, newer preparations, and glimepiride comes on top on this forest graph, right? So many studies, meta-analysis, chlorpropamide, tolbutamide, you can see they were discontinued long time ago and not very good, right? There's increased cardiovascular risk, but glibenclamide comes in the middle. But these two definitely, there are fewer or lower risk of all-cause cardiovascular related mortality. So without any fear, I would recommend that you all could use these medications. It will be especially very relevant in the current context. These are the large studies. Some of them have been published by the time when this slide was. So now the FDA approval for any diabetic drug, you need a cardiovascular risk assessment study or a follow-up study, because after the pioglitazone, fiasco, I would say that, it showed that meta-analysis showed that it will increase the cardiovascular risk. Later, it was disproved, and because of that, it's a requirement to do all these cardiovascular studies. But all the new preparations are having huge studies. They are well funded, so they have data. But these are older molecules. That's why I said we don't have much studies with the sulfonylureas, but the little studies and our experience, we can say that it's almost comparable, at least non-inferior to the other products. But there are empagliflozin and other products which will have a positive effect, which is not seen with sulfonylurea. They will reduce the cardiovascular risk. Liraglutide, empagliflozin, and the GLP-1 receptor agonists, the longer version. Those are a positive result, which we can't claim for the sulfonylureas. So, and this trial also same, treated with sulfonylureas and treated with pioglitazone as add-on to a treatment with metformin. It was the primary outcomes of cardiovascular risk was not significantly higher compared to the other products. Caroline, I think I explained before as well, and cardiovascular risk reduction, and it assures the safety. It's not a drug which will, cause any cardiovascular problem, but it does not have a positive effect as well. That's what this study showed. In the interest of time, in repetition, I will skip that. And of course, actually in this thing, I closed that, but that was not opening. So in the interest of time, I'll skip these things. It's the same thing that they are repeating. It's another set of slides that we had to put due to the, so, okay, so how can I go back? Okay, I'll skip that. So this is a paper where we were also involved, the South Asian Federation of Endocrine Societies. We came out with an international expert opinion among our 6 countries, 5-6 countries on sulfonylureas. So we have summarized all these factors, which if I may read, good glycemic control can positively influence the long-term development of cardiovascular disease and mortality. Cardiovascular safety outcomes offer advantages, but uniformity in reporting and recognition of specific off-targets actions of molecules, which were explaining before, is not there. Second and third generation SUs are not associated with an increased risk of all-cause mortality, cardiovascular mortality, MI, or stroke. We took all the available data and came to this conclusion. About 25 of us in that paper. So modern sulfonylureas are preferred over conventional sulfonylureas in patients with diabetes and cardiovascular disease. Glimepiride, glipizide, MR. Guidelines consider modern SUs to be cardio-safe. Results of the Carolina trial underline this cardiovascular safety of modern SOE. So we have reiterated, and 5 other Asian countries have adopted, and this, but of course the Westerners won't take this up, that easily. They'll have a lot of counter arguments for the newer expensive ones. Again, it's the same thing. Another paper, one of our colleagues, I think this is the Indian Heart Journal, they also did a similar thing. and recommendation for their country. Cardiovascular health. So these are preserves the myocardial preconditioning I explained. No effect on ATP sensitive potassium ATP channels. It's a variable response. So little or no effect on blood pressure, no effect on reducing coronary blood flow, which I have explained before briefly. I think there'll be more to come in the next lecture. So, ladies and gentlemen, the myths and the facts here. Efficacy, I think we are, all of us by experience know it works. Hypoglycemia, the modern issues are comparable to most other products, but you have to use with caution and proper dose for the patient, and certain precautions will have to be there. Of course, it's slightly more than metformin. The hypoglycemia risk is there. It's weight neutral, the modern ones, and beta glimepiride and the glycoside MR will be beta cell friendly. And the durability, when few slides I explained how durable they are over more than 5 years duration. So that's it from me. So the myths, debunking the myths about the sulfonylureas. I think it's a very timely matter that we discuss, because in the near future, I think we'll be going full circle back to these products, at least for some time, to be practical. And increasingly we are seeing, even today I saw so many prescriptions were changed. Even we have given metformin, sitagliptin, other products first because of this cardiovascular hype and things like that, but patients can't afford. I have been changing a lot to glycoside back even today in the today's context, because they say their bills have doubled or tripled, and they come and show the receipts now these days. Thank you very much.
Thank you.
Questions later?
Would you all like to ask the questions immediately after this lecture, because that may be fresh on your minds? So I think we'll ask the questions here, and then we'll take it up with the next lecturer. So if anybody has any questions?
Yes, I had some slides. Unfortunately, the slide didn't open up. So when you compare the glycoside and glimepiride comes on top. The most of the studies, the other studies, but glycoside MR is almost equal to glimepiride in most of the studies, but there are more studies with glimepiride, because glycoside MR also doesn't have many studies published on its safety and all that. Glimepiride has more data actually, but when you compare the hypoglycemia and all that, there are other studies, a Lancet paper, they had recently, it's almost equal. So modern issues, we would say glimepiride and glycoside MR, not the normal glycoside is inferior to glimepiride. That's what I believe in, and but there's no huge amount of data for all these things. That's the problem. No, sulfonylureas, as you know, will rapidly, compared to other preparations, will reduce the blood sugar, the glucose levels in the blood, right? When you give rapid acting metformin, if you take the whole process, so it gets attached to the sulfonylurea receptors and stimulates whatever the remaining insulin in the beta cells to be the stunned cells that release the insulin. When the insulin is released, the sugar levels will go down, which in turn, like a loop, will improve the stunned beta cells to come back to action. Got what I mean? It's like a vicious circle in a good way. And then that's what they were arguing in that study. So then it will improve the function quickly because it acts very fast, right? Compared to metformin, sometimes you might take 2 weeks for the full effect of metformin to set in. So if you want a quick reduction in the blood sugar, sulfonylureas would be the drug. Sitagliptins, those things will also work, but not as fast and effective as the sulfonylureas.
So basically what he is saying is that if you have a high glucose, your beta cells get stunned and therefore they start secreting less insulin. The moment you bring down the blood sugar, the beta cells get awakened and they start producing insulin. So that's what is called glucose toxicity, is to suppress the beta cell activity. And when you control the blood sugar, you improve the blood sugar by stimulating the beta cells which are dormant. So that is the more phenomenon why we have remissions. Now earlier they were saying that the beta cells die, right? It's really, they don't die. They remain dormant. They remain dormant. And that's why after bariatric surgery, the fellows who required insulin for 5 years, 100 units a day, come back to normal. Because the loss of weight just changes the insulin profile and the patients go into remission within 2 weeks after surgery.
We have patients 100 units a day of all medications after bariatric surgery. They're like 150 kilos, and if they come down to 80 or something, that fat in the pancreas, everything dissolves and the cells just wake up. It's amazing. Earlier we thought it's dead and you can't revive, all that, but now things are changing.
So we may call it beta cell hibernation. They are hibernating like the animals in winter. The metabolic rate goes low. And then when you decrease the weight, the whole beta cell wakes up and starts secreting. So we don't say that beta cells are destroyed, but we say they are hibernating and they are getting back. That is the mechanism of remission. How do you get diabetic remission? Suddenly patients said, I am fine. I took the medicine and for years, I am fine. And then after about some time, they may remit again, get diabetes again. So remission is that phenomenon is called hibernation. Just one explanation, Manilta. The earlier sulfonylureas, you see, their metabolites also continue to secrete beta. They continue to produce insulin through the beta cell. Whereas the modern ones, the metabolites don't have that action. Once they bring it down, there's no further action.
And that
so there's no
studies, they were telling, I also learned through that, read around it. So they say the older ones, once they get attached to the sulfonylurea receptor, the type 2 in the beta cell, there is one in the heart, 2 in the beta cell. It's a tight attachment and it remains there. The newer ones, especially glimepiride, it's off and on. It's like, not a very tightly bound molecule. So it releases and again, so it gives a break. So it's there is no continuous secretion of insulin from those, but other products and their metabolites, as he said, also will increase. So it's like a vicious circle where the sugars will be going down really, and they are releasing all the insulin they can. In other terms, might exhaust the beta cell reserve a bit. That's how the theory came those days. When you give these drugs, after some time, it just reserves go down and they gain weight, and that will add to the problem, goes into hibernation. Then we call it as insulin OHA failure, those days.
What are your views on hitting it hard at the beginning and then relaxing rather than stepwise increase of your antidiabetic
Of course.
drugs?
Our theory now, the modern thinking is hitting it hard early. If the sugars are very high, I would say 2 drugs, sulfonylurea, metformin, even start with insulin, which will help with the reversal regression process and get it down. Have a target HbA1c for your patient. Try to achieve it in 3 months or maximum 6 months, whatever it takes. 2-3 drugs plus insulin, hit it hard and get it down. So if you can convince some of our patients, because when you say as most of you see the newly diagnosed patients, if you suggest insulin to them, what their reaction would be. It's very difficult. But if you are very proactive and convince your patients to go on insulin, people who are especially having fasting blood sugars of 250 or 300 at the time of diagnosis with HbA1c of 10 or above, they might be able to go home on a metformin after, go home, or at least in 2-3 weeks time, they might be only managed with metformin most of the time, if you can give insulin to them. So that's the thing. We believe in hitting it hard early and then trying to reduce it over time.
Okay.
Okay. Thank you.
Okay. Thank you, Anilka. Are you going to introduce the second speaker? Right. The next speaker is Dr. Upul Vikramararachi. He is a cardiologist now practicing at the Lanka hospitals. He passed out MBBS in 2005 from the University of Peradeniya, and then he went abroad and he ended up as a cardiologist through the special accreditation certificate in cardiology. And he was trained in a number of centers in England. From 2020, he was certified as completed training in cardiology. And he also did a research work and got a doctorate of medicine, right, in drug-coated balloon angioplasty. He is now attached to the Lanka hospitals. He has many publications. Anyhow, his main place is that he left Sri Lanka probably about 3 years after your qualification internship, and he has returned to Sri Lanka and now practicing as a consultant cardiologist. So I have great pleasure in calling Dr. Upul Vikramararachi to give his lecture on acute coronary syndrome. Over to you, Upul.
Thanks very much, Dr. Henry Rajaratnam. Good evening to you, and good evening to all of you. And I'd like to thank, first of all, Dr. Hazari, the president of Independent Medical Practitioners Association in Sri Lanka, for extending this invitation to me. And I consider it a privilege to be speaking here. And thank you all of you for being here physically, and also all the people who are joining online. And thanks for your very kind introduction. Thanks. I left actually immediately after graduation.
Yeah.
So the topic given to me is acute coronary syndrome, which is a bit of a broad topic. I'll try and keep it as succinct as possible in the interest of time. Okay, thank you. So before talking about the definitions and pathophysiology, etiology, I'll just mention a few words about prevalence and the burden of ischemic heart disease in Sri Lanka. Sorry, the slide is a little blurry. Not sure why. So still, if you look at the in-hospital mortality, ischemic heart disease is the topmost reason. The numbers from 2019 suggest that we had about 40 per 100,000 deaths. This is in-hospital data published by Ministry of Health. And if you look at the presenting symptoms, actually, surprisingly, ischemic heart disease symptoms are not at the top, but nevertheless, still the top killer, I would say. If you look at the global perspective, sorry, there's a little old data, I couldn't find the most recent data. This is, sorry, can I? Is there any way to have the whole screen, please? I can't see the bottom of the slide. So this is males and females, males and top, females at bottom. And if you look at, we are in light blue shade, around about 15 deaths per 100,000. And if you, the darker the blue, the better your mortality, as you can see. So we're somewhere in the middle or a bit closer to, be doing good. But if you look at the Ministry of Health data, actually, it's a slightly different picture to this. Maybe our neo data is not so good, I don't know. If you look at age and gender, as everyone knows, obviously being a man puts you at higher risk of developing acute coronary syndrome. And the age to reach, let's say, 10%, 10 per 100,000 deaths would be, 50s, mid-50s for males, whereas, sorry, the slides are really not clear. I do apologize for that. It was not the case. I don't know why, maybe zooming issue, but females, it'll be mid-60s, as you know. So that's age. Okay, there were 3 lines connecting acute coronary syndrome to STEMI, non-STEMI, and unstable angina. You probably can't see it. So acute coronary syndrome is described as these 3 entities that are the ST elevation MI, non-ST elevation MI, and unstable angina. And I have put this little circle with type 2, 3, 4, 5 MIs just on the outskirts, not connecting directly, just to say that there's some overlap. And when you dissect down into these definitions, there's some overlap and some blurring of lines. The ESC definition is much broader, so that includes all the cardiac arrest, the mechanical complications of acute coronary syndrome, and to the good old chest pain patient presenting with a non-STEMI or a STEMI or unstable angina. I think for simplification, we'll keep it as those 3 entities that I mentioned before. To go through the universal definition of MI in 2018, the 4th universal definition says you have to have a rise in high sensitivity troponin more than the 99th percentile, together with at least one of the 5 described below. This, symptoms of myocardial ischemia, new ischemic ECG changes, pathological Q waves, imaging evidence such as regional wall motion abnormality on an echocardiogram, and intracoronary thrombus found on an angiography or in an autopsy. Type 1 myocardial infarction is what we mostly refer to as a heart attack. Is characterized by atherosclerotic plaque rupture, erosion, fissure, calcific nodule, leading to intramural thrombus formation, causing a degree of coronary flow obstruction and myocardial necrosis. There could be varying degrees of stenosis, and also about 5 to 10% of patients do not have obstructive coronary artery disease, which most of the time we call as MINOCO, myocardial infarction with no obstructive coronary arteries. Type 2 myocardial infarction, I'm sure you're familiar with this phenomenon. It's basically a mismatch between supply and demand rather than a plaque disruption. In any condition that can cause tachycardias, bradyarrhythmias, anemia, hypothyroidism, sepsis, renal failure. Most of these conditions can cause troponin rise, but we call it type 2 myocardial infarction. Also intracoronary wise, the coronary spasms, the spontaneous coronary artery dissections, which we see commonly in middle-aged females, and also coronary embolism from other sources do also fall under type 2 myocardial infarction. Type 3 to 5 are more of academic interest, I'd say. Type 3 is where someone has died of MI but didn't have time for the clinicians to record a troponin rise. Type 4 is PCI related, either as a complication of your percutaneous coronary intervention or subsequent stent thrombosis, the two types of type 4. Type 5 is post-bypass surgery, myocardial infarction. Pathophysiology, so it's the dissolution of fibrous cap, the major trigger for coronary thrombosis, and then as a result of release of metalloproteinases from activated inflammatory cells. And this is followed by platelet activation, aggregation, and then activation of the coagulation pathway, coronary spasm. So all these three act together to cause coronary thrombosis. Yamamoto published in American Heart Journal in 2019. This is in studying ST elevation MI and non-ST elevation MI patients using optical coherence tomography, OCT, which is an intravascular imaging method. If you look at STEMI and non-STEMI patients, in STEMIs, plaque ruptures accountable for almost 60% of patients, plaque erosion about 30%, calcified plaque about 10%, and surprisingly, non-ST elevation MIs, plaque erosion percentage was higher than plaque rupture and then the calcific plaque. Just to summarize the OCT appearances. So this is inside a coronary artery. This is the OCT wire, and this is a plaque rupture where there's a fissure and discontinuation of the fibrous cap. In a plaque erosion, this is an artifact from the OCT wire inside the coronary artery. The fibrous cap is intact, but there is, the thrombus is not on this slide, but thrombus formation just on the endothelium. In a calcified plaque, this is calcium deposits, these dark bits, some endothelially, and this is thrombus formation. So these are from OCT classification, different mechanisms of acute coronary syndrome. I'm really scared of this slide. I think this slide probably can easily produce 2 PhD theses. So this is the ischemic and physiological factors contributing to plaque vulnerability. The way I'd like to summarize this is that it's a multifactorial process, including shear stress, the messengers, the metalloproteinases, pro-inflammatory cells, causing the thin cap fibroatheroma, ultimately causing a rupture, causing the acute coronary syndrome. And also, FFR refers to how the coronary flow is affected across the stenosis. So if FFR was more than 0.8, we say it's non-obstructive. Right. This is going on to risk factors for acute coronary syndrome. Normally, we describe modifiable risk factors, describe them as modifiable risk factors or non-modifiable risk factors. But I thought this slide by Zulaki, again, in American Heart Journals, 2018, was very beautiful in describing the risk factors to truly say how multifactorial the acute coronary syndrome or ischemic heart disease is. So, starting with poor socioeconomic backgrounds, poor nutrition, sanitation, and then goes into poor diet, processed meat, increased salt, less fruits and vegetables, less whole grain food, increased trans fats. I think, our dietary habits, especially in the urban and suburban areas, are, they have a great resemblance of this. And then physical inactivity, smoking, alcohol, all of that, high adiposity, genetic influences, then causing, hypertension, dyslipidemias, diabetes, thrombosis and inflammation, causing subclinical atheroma, and then resulting in culminating in cardiovascular disease, ischemic heart disease, stroke, failure, peripheral arterial disease, all of that. Right. In terms of how are the risk factors connected, just to summarize again. So if you look at hypertension, it's mainly vasoconstrictor hormones with hyperglycemia and dyslipidemia, product of glycoxidation, and pro-inflammatory cytokines from excess adipose tissue. These are how these the pathological effects are brought upon. And obviously the mononuclear effects as T lymphocytes, the immune mediators play a great role in this. Right, the most interesting part as clinicians for us, clinical presentation. I use this figure from ESC guidelines just to elaborate on where the chest pains people complain of. So in the front of chest, central chest pain, tightness, heaviness, shortness of breath. In singular, they say hatiya, dadidana, epigastric pain. This is all radiant to arms, jaw, teeth, very likely to be ischemic heart disease. I always ask patients, show me where the pain is. And if they try to explain, I say, no, show me with your hand, please. So if they use the palm or their full hand across the chest, I know that this is, it's likely to be described, them like to be describing ischemic heart disease rather than pointing with their finger to one particular place. Now, history, physical examination is of paramount importance. So, if someone coming with chest pain says, I've got some weakness in my leg as well, I felt presyncopial, you should immediately be thinking about other diagnoses like dissection. So history is still very important, and physical examination findings will be helpful to exclude other differential diagnoses, like feeling all the pulses, your initial at least a brief neurological examination, just to make sure that it's not something else. If the patient says I'm short of breath, and you find that his oxygen saturation is on the lower side, but yet no heart failure signs, tachycardic, think of pulmonary embolism straight away rather than acute coronary syndrome. So, it's to keep an open mind of these patients, just not to be bogged down with a raised troponin level is very important. ECG under 10 minutes of arrival, this is gold standard, should be practiced in every healthcare institution. You miss a golden opportunity to save some myocardium. Otherwise, people lying on a chair or a table and not having an ECG. Just a few ECGs for everyone's benefit that we cannot afford to miss: anterior STEMI, inferior STEMI with stimulations in the inferior leads, just a refresher, lateral or high lateral STEMI, posterior STEMI with tall R waves and ST depressions in the anterior leads. Someone with acute chest pain, a left bundle branch block, still an indication for primary PCI. And this ECG included not a primary PCI indication, but still a very important ECG of Whelan syndrome, unless proven otherwise. It's approximately LAD critical stenosis. So you have to look after them very, very carefully. So high sensitivity troponin has really changed the game, I should say. I remember the days where we have to wait for admission troponin and then another 12-hour troponin to exclude acute coronary syndrome. But now things are much, much faster, much quicker. We do one on admission, depending on your hospital. Let's say you can do another one in 3 hours or 6 hours. And if it's negative, you can say safely that this is not an MI. But still, as I said at the very beginning, history is very important. If someone's giving you a very clear history of crescendo angina, troponin negative, that's where the unstable angina would come into action. We should, in my opinion, I don't think we should be discharging those patients. If your history is very convincing, maybe some ECG changes, you should think of unstable angina and be careful. So what has high sensitivity troponins done to us? They've got higher negative predictive value for acute myocardial infarction. The troponin blind period, now the previous generation of troponins would take about 4 hours to appear in blood, but the high sensitivity troponin would start appearing in the first hour of the myocardial injury. So this is very helpful for us clinicians. Whereas before 4 or 5 hours, we would know what exactly the diagnosis, but now ruling is easy. Starting treatment, if you find out, has been made easy for us. 20% relative increase in detection of type 1 MIs, where most of these people we would have labeled them as unstable angina before. This has also led to an increase in diagnosing type 2 MIs. Some might think this would muddy the picture, but I think it's still useful information for you to know. Other investigations, full blood. This is someone who is suspected to be having acute coronary syndrome. Full blood count, renal functions, baseline liver function test, lipid profiles, random blood sugars, HbA1c, chest X-ray, echocardiography, the basic things that we do. differential diagnosis of acute coronary syndrome in the setting of acute chest pain. It's a bit of a list, but I think, again, just to keep an open mind of all the possible differentials from myopericardite to cardiomyopathies, tachyarrhythmias, Takotsubo, valve pathologies, coronary spasm, cardiac traumas, and a young person in a 25-year-old coming after overnight party, with ST elevation, most likely to be coronary spasms after some illicit drug use. So you got to keep an open mind. Then pulmonary embolism with deep T anterior T wave inversions, which could mimic anterior ischemia, but if you look into history and examination, this could be just RV strain with pulmonary embolism. Then aortic dissection, as intervention is, you get patients brought straight to the lab with as inferior MIs, and actually to find out that unless you are very careful in that brief 5 minutes where you take your history and examination before taking them to the table, that it could be very well an aortic dissection that you're dealing with. And then the good old esophageal spasm, even to the most experienced clinician, it could be very, very difficult to distinguish an esophageal spasm from angina because it's chest tightness, it's heavy, it's tight, it's relieved by GTN. So, in these situations, high sensory troponin has really done us a great job. Okay, and then other conditions where there is a troponin leak, there's cardiomyocyte injury, but not quite acute due to acute coronary syndrome. The list continues. Actually, this is also interesting. Patients sometimes to be aware of the acute neurological events and other things like rhabdomyolysis. Infiltrative diseases, amyloidosis, hemochromatosis. It's not that uncommon in Sri Lanka. Even for the last few months, there have been at least a couple of amyloid cases. So yeah, it's not that uncommon, I should say. So management, analgesia is the a key. If someone is in pain in front of you, you start with analgesia. Morphine is still the gold standard of analgesia. Antiemetic followed by an antiemetic. Oxygen saturations, if it's less than 94%, we give oxygen. Aspirin and P2Y12 inhibitors. So for ST elevation MI, if PPCI is available, PPCI is primary PCI. If it's available or achievable under 2 hours, you should definitely refer for a primary PCI, and if not, thrombolysis should be considered. Now, I'll speak a few words. Obviously, as you all know, time is muscle. So every minute that you lose when there's an ST elevation MI, you're losing myocardium. And to be honest, the last time I thrombolized the patient was in 2008. That's about 14 years ago, as a foundation year 2 doctor, equivalent to a senior house, a first year senior house officer. That's in Scotland. And after that, we've had access to primary PCI for every patient since around that time in the UK. So you can see there's a vast difference in how we manage our patients here. There's a lot more room to improve. Obviously, we have to understand we are dealing with very low amount of resources compared to other countries. Yet we should improve, I think. So we have to always remember time is muscle. And then and also PPCI is one treatment where mortality had, most than now, as with the ischemic trial, PCI for stable patients, we know is only for symptomatic benefit. But this is one area where we have shown that intervention can improve mortality, so we should strive for. So non-STEMI, other than the aspirin clopidogrel, the low molecular weight heparin or unfractionated heparin, the beta blockers, ACE inhibitors, high dose statin, and admit to unit with some rhythm monitoring facility. This is this slide to summarize the two pathways in treating, in deciding antiplatelet anticoagulants. So to stop the platelet aggregation activation, we can use the thromboxane A2 inhibitor aspirin, the ADP receptor blockers, the clopidogrel, prasugrel, the tecagrelor, the newer ones, and also cangrelor, and GP2B3 inhibitors for high-risk patients used to like tirofiban or eptifibride use. And then enoxaparin, fundoparinox as factor 10 inhibitors to use the coagulant pathway. mainly these are the ones that have been used, bilirubin, dabigatran. These are not in the acute setting, I should say. So loading doses with ST elevation MI, we load with aspirin 300, clopidogrel 600 milligrams. If it's ticagrelor, it's 180 milligrams. If it's prasugrel, it's 60 milligrams. But with prasugrel, we load with after PCI. Non-STEMI, aspirin 300 milligrams, clopidogrel 300 milligrams, ticagrelor 180, and prasugrel 60 again post PCI. Low molecular heparin, we use Fundoparix in the UK, but I don't think it's available here. We use enoxaparin 1 milligram per kg subcut BD. Invasive treatment for or revest timing for non-ST elevation MI. Excuse me. So this is changing as we speak. Even for non-STEMIs, if there's hemodynamic instability, if there's cardiogenic shock, now the accept ways we treat just like in STEMI and try to revascularize under 2 hours. High-risk patients, there are high-risk criteria. We try to revascularize within 24 hours. There's something called rapid non-STEMI pathways that are being developed, and the others we try to revascularize within 72 hours if they're deemed suitable for invasive strategy. This slide summarizes that. This is from the ESC guidelines in 2020. Very high-risk patients, with any of these features, we tried and revascularize within 2 hours. And if, especially grace risk 140, I mean, here, if you look at the guidelines, it says if there's an established diagnosis of non-STEMI, there should be revascularized within 24 hours, but actually in practice, it does not happen. I remember at Royal Papworth Hospital when the rapid non-STEMI pathway was established in 2019. Other than the clinical criteria, there were other criteria such as mobility, if to be able to be discharged early. Those were some clinical criteria. Otherwise, we would not be able to keep the beds free to facilitate a very high turnaround of these patients. So not just clinical criteria, other criteria like less comorbidities. The relatively younger patients got revascularized within 24 hours, even for non-STEMI high risk, especially gray score more than 140, or ongoing chest pain, dynamic ECG changes despite initial medical treatment. And the others usually gets done within 72 hours. Right, this is gray score. All gray score calculators are available widely online. Use age, heart rate, systolic blood pressure, creatinine, heart failure status, whether they had a cardiac arrest or not, ST segment deviation, elevated cardiac enzymes. It's pretty easy. So post-PCI, dual antiplatelet therapy is recommended for 1 year, apart for in high bleeding risk patients, single antiplatelet lifelong, and very high ischemic risk patients. There are indications for extended dual antiplatelet treatment, such as ticagrelor 60 milligrams BD. We use clopidogrel, that's fine, I think, in extended risk patients. And pharmacological long-term management. So statins, as you know, with LDL, it's like it's a race to the bottom. So the lower your LDL, the better. That's what the latest guidelines suggest. So this number keeps going down and down. I'm not sure how much, in what percentage of patients we'll be able to achieve this. But right now, the guidance is less than 55 milligrams per deciliter. And then to add other agents if they are not achieved. And if they had an MI within 2 years while being on high dose statins, then target is less than 40. ACE inhibitors preferred to ARBs, especially if the EF is less than 40. And then the good old beta blockers, and also mineral core receptor antagonists for ejection fraction less than 40, spironolactones, proton pump inhibitors as well, especially if they are on dual antiplatelet therapy. The elderly cohorts would benefit from that. Excuse me. So discharge, STEMI patients, we tend to discharge in on the 3rd day, after 3 days. Non-STEMI patients usually after 48 hours, and usually they get reviewed by a cardiac nurse in about a week's time. And then by a clinician here. I think it's usually a clinician-led follow-up here. The most importantly, cardiac rehabilitation, which most of us clinicians do forget, because that's where the patients build their confidence to get back to their normal life. So, everyone will have questions about what can I do next? Oh, can I drive a car? Can I ride a bicycle? And when can I get back to my normal life? So cardiac rehabilitation is very, very, very important. Right, that brings to the end of my talk. Some new fronts, so rapid non-SME pathways are coming, at least in the Western world, they're coming, they're already being established and rolled on slowly across countries. Then recommendation of prasugrel over clopidogrel and ticagrelor, and especially the ESC guidance is clear on that. But in real life, it's still not happening. I checked today as well with my colleagues there. So, for example, for East of England, where across Royal Papworth and Norfolk and Norwich, the two primary PCI centers, still ticagrelor is being given, not prasugrel. But in Liverpool, it's prasugrel. So there are differences. But personally, I am still using ticagrelor, not prasugrel. Maybe we'll have more experience in time to come about these new agents. And the new biomarkers are also coming, but certainly not recommended by the guidelines yet. Take-home messages: good history and physical examination is of paramount importance. Time is muscle. Not every troponin rise is acute coronary syndrome. Target-driven secondary prevention and cardiac rehabilitation plays a key role. Thank you very much, everybody. Thanks.
Questions to the audience?
Thank you very much, sir. I would like to invite both speakers to the head table so we can have a Q&A.
All right, fine. We need another chair.
Yeah.
Ladies and gentlemen, when I saw the curriculum vitae of these two visiting consultants, I was sort of thought there are a lot of coincidences in these three group people on this head table. First thing I noticed that we are all three royalists, right? Secondly, two endocrinologists here, and but he may not know that I was a registrar in cardiology at the Happy Hospital, and did work on coronary arteriography in the 1970s, right? So that's 50 years ago, right? So we have got a lot of affinity, right? So anyway, just to ask you a question to start off with, I was impressed that in your protocol, the MI, you put the random blood sugar and HbA1c at the same time. What is the rationale you used for that?
I think HbA1c would be obvious to get an idea about the glycemic control over the last 3 months. You could say that would be useful more in established patients with an established diagnosis of diabetes rather than everybody. So the practice would be, if the random blood sugars are normal, I don't think any one of us would check HbA1c.
Yeah, but I think you have to do both at the same time as on admission, because the random blood sugar will tell you what the sugar situation is there. But the elevated blood sugar by itself doesn't mean that the patient is diabetic. It's just that it is stress hyperglycemia. But if you find an HbA1c at the same time, then you know patient has had diabetes for the last 3 months, and on top of that, he has got a stress hyperglycemia at the same time. And they have an index between the A1C and the random blood sugar, which tells you how serious the infarct is and what the prognosis is. So I was, now, what about using SGLT2 inhibitors after an infarct when the patient is stable? What do you think of in a non-diabetic?
I will not, in a non-diabetic, if there's no evidence of heart failure, I will not use it at present. If there's evidence of heart failure, then yes. In my view, obviously I will take your advice on this. I think that dapagliflozin has got maybe slightly bit isolated mortality benefit over empagliflozin. But certainly, to answer your question, in the presence of heart failure only.
Okay. You have
There
any
is,
thoughts on that?
Yeah, there is no evidence, as he said. Of course, the major studies have been the DAPA-HF and the Emperor Preserve and all the studies. It's if there is element of heart failure with preserved or reduced ejection fraction, there is a case, but not otherwise. But of course, it's a wonderful drug, and all the cardiologists will take this up before us in future, I think. Already the European Association of Cardiology, ESC, has recommended persons with high cardiovascular risk and established cardiovascular disease. First line therapy for diabetes would be a SGLT2 inhibitor in Europe. So because the theory is that it causes a mild ketonemia, and the myocardium is supposed to utilize the energy better when there is a, through the ketogenic pathway. There is a theory like that. It improves the oxygen consumption, reduces the oxygen consumption. So there are so many plus factors, but in Sri Lanka, the cost now, it has gone over the roof for all these products, being more than 100 rupees a tablet. So I don't think in the near future we'll be able to do that.
Yeah. I also noticed that in your protocol, you mentioned to give oxygen after an MI only if the oxygen saturation is below 94%. Can you explain the rationale of that, please?
That I have to say, I do not remember the studies that specifically, but certainly I do not remember the name, but there was evidence to suggest that giving high flow oxygen to everybody across board caused more damage, caused more harm than good, especially, the one with who are prone to retain CO2, develop acidosis. Those patients would be at risk. So, but sorry, I can't remember the exact studies to quote.
Have you any comment? Well, I think the study showed that those who had more than 94% they given free oxygen, as we gave those days, routine oxygen as soon as the patient came with an MI, that the infarcts are bigger. So I saw in your protocol. Now, what are your views on how far down can you reduce the LDL in a person with ischemic disease? Those days we said LDL 100, then we came down to 70. Now you say 55. How low can we go?
According to the experts, it should be as low as possible. But in real life, I don't think. Well, it's very difficult to achieve LDL of 55. I would say post MI, if I see someone with 70, less than 80, I would be happy. I would not be adding a second agent if it's around 70, 80. But if it's around 100, I would certainly stress that we need to do better here. This is, I'm talking about on a post MI patient, not the stable angina patient or patient sitting on your PD clinic.
So on a routine, what would be the average dose of a statin you would use? Say atorvastatin or rosuvastatin?
Atorvastatin 80 milligrams, that's the recommended. Atorvastatin 80 milligrams, 80 yeah, post MI.
Is that for all ethnicities like Asians also?
That I do not know. We use for all ethnicities, but scientific evidence, I do not know.
Yeah. So, I mean, we see having worked here for, I know in UK, 80 is nothing, everybody is, 18, but there is something in Sri Lankans which they really don't tolerate 80. There are muscle pains, aches and pains, the CPK might go up, and even there are a few instances of rhabdomyolysis. So I know cardiologists prefer, and initially they give, but even most of the cardiologists who have been here for a long time, I think they stop at 40. We can ask our senior cardiologist here what his practice is. We are very scared about 80. The guidelines, we stop somewhere around 40. But the Sri Lankan seems to be responding it to well, and of the side effects steeply go up after 40, at 80. What are your views? I think it's a good question. If you can comment on that.
Yeah, as Dr. Manilka told, our patients, for some reason, all these patients don't tolerate 80 milligrams. So they usually come with symptoms. So usually most of our cardiologists and the community is happy with 40 milligrams of atorvastatin or rosuvastatin. In case if you need to reduce more than that, you add ezetimibe to that 10 milligrams, and that's the job most of the patients, right? And very few patients we get where the levels are not going down. So when you add ezetimibe, it brings another 20 to 25% reduction from the line where we stand. So that is helpful drug with minimum side effects.
Can I ask him a question?
Yes, of
The
course.
burning question I have is, I didn't know the topic. I threw the ischemic preconditioning, which I was waiting for. Your PhD slide, it's very interesting. We have studied some of those molecules. What is your view about the vascular endothelial growth factor? I think that is the one which promotes the collateral production. Have you got any idea about how this, although I mentioned, I didn't really understand the pathophysiology of how the older sulfonylureas block the preconditioning. I can tell you that the physiology, there is the sulfonylurea receptor, and it affects the potassium channel. So do you have a clue somewhere from a cardiology side how this is blocking? I mean, it's well understood, they have said. I was wondering whether this is blocking the vascular endothelial growth factor in some way in that slide he showed. Any ideas?
No, only thing I can tell you is you will block the potassium channel and open the calcium channel for the calcium ions to come into the beta cells and then stimulate the insulin to go. That's the normal mechanism. More intricate mechanism, I don't.
Yeah, something must be blocking the action of those factors which causes the angiogenesis. Okay.
Now, I just want to ask you, which I didn't ask you. Now, glycoside MR and glimepiride, which do you prefer?
I use both equally, but I think this is no evidence at all, I must say, but I see people who are on a lighter diet, on vegetables, salads, and less carbs, glimepiride works much better. And in Sri Lankans who are 3 times a day rice eaters and high carb diet, I go for the glycoside MR, which seems to have a slight edge on, getting the levels down. And the hypoglycemic tendency also may be slightly more than glimepiride, but that's the downside. That's my practical experience, but both are very good drugs.
Cost-wise, important in Sri Lanka?
Cost-wise, I think the dose per glimepiride will be more cost-effective, because even 1 milligram of glimepiride might, bring down the sugar, where you might need about 30 to 60 milligrams of a glycoside MR to, get 2 milligrams. So we need to check the price. The prices are all over the place. They are, I mean, I can't figure out the amounts. They are gone by leaps and bounds. So we need to reassess.
Price rise, it's evolving.
Right. So
from day to day, right. Any other questions from the audience? Secondary beta cell failure, oral hypochlorous failure. Is it a different mechanism from what? From
different mechanism. Okay, so actually this is very new. The last year or so, that's how the people came out with that they don't believe anymore in beta cell destruction. Of course, I have given lectures saying 50%, by when the type 2 diabetes is diagnosed, 50% of your beta cells are dysfunctional. Oh, we thought it was destroyed, not to come back. And then over time, it goes down. And then when the levels are very low, you need insulin. So that's our traditional conventional thinking. But there is, after the SGLT2 inhibitors and this bariatric surgery data coming in, we have seen that that's not the case. It just reverses. So that's why Sir also said it's a hibernating beta cells that that is supposed to be there, and it can be reversed by reducing the intrapancreatic fat. So it's a fatty pancreas, like the fatty liver. It's covered with fat, and if you dissolve that fat by some losing weight and some mechanisms and the newer agents, you could reverse vast number of this thing. We don't know the exact, this thing. So it's a change in our this thing. I agree. We may have taught this, and we have learned this. The mechanism of OHA failure, but it may not be real if you reduce the weight by 15% in an obese person in a BMI of about 30. There is a good chance that there can be a reversal, may not be 100%, but to a certain degree. So now we have to take our word back and readjust to the new evidence.
Okay. That's okay. Any other questions from the audience? Okay, then, ladies and gentlemen, I think we have had a very interesting discussion, and we have to thank Manilka Sumanathilaga and Upul Vikrama Arachi, right, for their erudite lecture and for the information they have given us. Let us all show our appreciation in the usual manner.
Thank you very much, sir. So we have a small token of appreciation for the speakers, Dr. Hazari.
I'm very sorry, in the mix up with the slides, I forgot to thank Hazari and IMPA, of course. A very familiar place for me to come and give lectures, and thank you very much for the invitation and for all of you.
Okay.
Kindly bear with us for a few more minutes. Distinguished guests, ladies and gentlemen, as we come to the close of another very successful CME, there are a few people that I wish to make special mention of, without whom this meeting would not have been a reality. Firstly, our distinguished panel of speakers, Dr. Manilka Sumanathilaga and Dr. Upul Vikramarachi. We at Sanofi are truly thankful and honored to have had such a distinguished and august faculty. Thank you, sirs, for taking the time off to prepare and be here with us in person amidst all of the difficulties, and which we truly understand. We're truly grateful and thankful to both of you. Dr. Henry Rajaratnam, sir, it's our warmest regards and appreciation and an honor to have you with us today, sir. And thank you for your willingness to share the meeting tonight. We're most humbled to have had you here tonight, and therefore a heartfelt thank you to you on behalf of all of us at Sanofi. We're also truly thankful to Dr. Hazari and the membership of the IMBA for your collaboration with Sanofi to host this our first joint CME. And we, of course, look forward to many more in the months ahead. I also wish to thank our staff, Sandhya, Priyadarshan, Pramod, Bhatia, and all of our other Sanofi staff, Dr. Kaushalya, for making all the arrangements necessary and for making this event a reality. And the staff and management of the Cinnamon Lake Hotel for your support in the weeks leading up to this meeting. A very big thank you to each and every one of you, our distinguished guests, invitees, without whom we would not have had an audience to begin with. Also, I want to thank all the those joining with us online. Thank you once again for making it in spite of all the difficulties once again. Ladies and gentlemen, Sanofi continues its journey towards making better the lives of patients and supporting this academic and educational needs of the medical fraternity. And we look forward to meeting you at a similar forum again. Thank you once again, and let me invite all of you to dinner and cocktails. Good night and see you soon. Thank you.
When I came to Sri Lanka, I asked for cardiology. They refused.